Have we started? Yes, hello. Hello, everyone. I'm Vasilios Minas. I'm a gynecologist and endometriosis specialist here at the Runnymede Hospital, and I hope that you can all hear me. If you cannot hear, write something on the send a message through the Q&A, but I'm hoping that you can all see me and hear me. We're going to start this session, and I've got here Tracy and Ellie with me, the two members of staff at the Runnymede Hospital who have done a fabulous work in setting up this meeting. And they've invited me to present to you today as the director of the Endometriosis Center here at the Runnymede Hospital in Surrey, one of the very few endometriosis centers fully accredited by the British Society of Gynecological Endoscopy in the private sector. We will talk to you about endometriosis. We will explain a lot of things about endometriosis and why it matters. And I will show you some slides, which will take approximately 40 to 45 minutes. And then we will have another 45 minutes to answer your questions. We have muted all your microphones because we expect a large number of people, and it will be possible for everybody to speak and ask, but you will be able at the second half of the meeting today to type your questions, and I'll try to answer as many of them as possible. So thank you all for taking your evening to join us, and I can see there are some people joining as we go. We'll see what time it is. It is 6:03. We'll give it a couple more minutes, and at 6:05, we will start the formal presentation. The Runnymede Hospital is in Surrey, just outside the M25, west of London, very conveniently located. Not in London, but not too far from London. And the area is very fresh and leafy, and we're a very, very friendly private hospital here with an endometriosis center which does very good work for patients all across the United Kingdom. So it's lovely to have you all with us. It's 6:04. Give it another minute, and we'll start our presentation. So let's talk about endometriosis then. There are a few subjects that we will touch upon. We will explain what endometriosis is and why it is important. We will talk about your diagnostic journey as patients. We will talk about how to navigate your care through the system and through the difficulties that the system often raises. We'll talk about surgical strategies to manage endometriosis. We'll talk about becoming pregnant, becoming a parent when you suffer with endometriosis. We'll talk a little bit about some common myths around endometriosis. We'll try to bust some of the most common myths out there around endometriosis. We will talk about how you can get help, the right help at the right time. And finally, we will close the meeting. We'll have approximately 45 minutes, so plenty of time to answer any questions that you may have. So, what is endometriosis in a snapshot? Endometriosis, by definition, is abnormal tissue that looks like the lining of the womb, which we call endometrium, and which lines the cavity of the womb, but it implants and exists in areas outside your womb, and that's when we call it endometriosis. It seems to affect about 10% of women in reproductive age. It seems to start from early reproductive life, so from the teen years or early 20s of women. Unfortunately, the diagnosis time can take 7 to 10 years on average, still these days, from the moment that patients present to the doctors or to a clinician or to a healthcare professional with symptoms related to endometriosis. It can take a while, unfortunately, still to get a conclusive diagnosis of endometriosis. These are the problems of the system for which we try to educate both clinicians and patients to shorten this period of time to a lot less. It is linked with subfertility, with difficulty becoming pregnant. About 30 to 50% of women will have subfertility when they suffer from endometriosis. And the most common symptom is chronic pelvic pain. Chronic means long-term, more than 6 to 12 months. And that appears in about 70 to 80% of cases of endometriosis. So the majority of women with endometriosis will have some pain, which can range from mild to severe. Where is it found? By definition, it lives outside the uterus. And it can find itself pretty much in any part of the woman's body. The most common area is the pelvis and the peritoneum, which is a membrane that lines all of our insides, the inside of the abdominal and pelvic cavities. That's where we find most cases of endometriosis, but it can also be on the ovaries, the fallopian tubes, on the surface of the uterus, on the bladder, and into the bladder wall, inside the vaginal walls, onto the bowel and into the bowel wall, into the abdominal wall, or on previous cesarean section scars, but also in other remote places, such as the chest, the diaphragm, lungs. It has been reported virtually in all parts of the human body, and if you search long and hard, you'll find somewhere a case report of an endometriosis in very unusual places, including the human brain. We're becoming increasingly interested in endometriosis that affects the pelvic nerves. These are the nerves that cross through the pelvis to reach the areas that they innervate in the lower pelvis and legs. And this is something that we've brought slowly in the United Kingdom, and we are one of the few centers that manages these type of problems. So what does it cause, endometriosis? The predominant symptom, as we said, in 70 to 80% of women will be pain. That can take various forms. It can be pain during the periods, during the premenstrual days. There can be heavy periods, mostly linked with adenomyosis, and we will talk about that a bit later. Pains during sex, to the point where some women may not be able to have sex because of the significant pain that they feel. Pain when they open the bowels, when the bowel is affected by disease. Subfertility, as we said, difficulty, which means difficulty becoming pregnant. And as you can imagine, somebody who's in pain a lot of the time will not feel very happy about it. And if somebody is in pain for several years or decades, as some of our patients, when they eventually come to us, they may be depressed and they will feel tired a lot of the time, which is not only due to pain, but also because endometriosis is an inflammatory condition. It causes chronic inflammation. And we know now well that chronic inflammation, can cause fatigue. So how do we approach endometriosis? The foremost important aspect of the approach is to have a multidisciplinary team around you, a team of competent people who have an interest, who specialize in the management and diagnosis of endometriosis, and they will consist of various specialties, both doctors and nurses. So the doctors will include a gynecologist, at least one gynecologist with a special interest in endometriosis and special expertise in endometriosis, bowel and urological surgeons, radiologists who can diagnose endometriosis on MRIs and scans, specialist nurses, physiotherapists, particularly pelvic floor, or we call them women's physiotherapists, who look after the pelvic floor health, which is often involved in women with chronic pain, pain specialists who look after women in the long term and can manage, we can offer various strategies and medication tailored to each woman's needs. Clinical psychologists, we're becoming increasingly aware for the need of psychological support, which goes without saying for people who've been in pain for many, many years, and fertility specialists. So how does the diagnostic journey looks like in a woman who suffers or may suffer from endometriosis and relevant symptoms? So usually your first contact with a clinician, the clinician should obtain a history. From your history, they should raise the suspicion that you may suffer from endometriosis. That should be followed by an examination, often an internal vaginal examination, which is important. I know it's not a comfortable or pleasant examination, of course, but it is important. It gives important information about the presence of endometriosis in a woman's pelvis. Ultrasound scan, which cannot detect many forms of endometriosis, but is very good in diagnosing ovarian endometriosis in the form of endometriotic cysts. Followed by that, a lot of these, up to this point, a lot of this in the United Kingdom will have been done by the general practitioners, and they will also initiate some treatment often with medication, usually hormonal contraceptives, which we will talk about later on. And if that doesn't work, or if there are signs and symptoms of severe endometriosis, the patient will usually be forwarded on to a specialist, such as ourselves, where often more specialized examinations will be performed, such as an MRI, pelvis, and a laparoscopy, which means keyhole surgery, which is eventually the gold standard for diagnosing endometriosis in the pelvic and abdominal cavities. However, in reality, sometimes the journey may not start in this as a straight line. That's why the arrows have both directions. So you could pick up endometriosis on an ultrasound scan or an MRI for the first time, or in a laparoscopy for the first time, and then move on to treatment and go a little bit backwards in this kind of straight line. A very important message for patients with endometriosis is to remember, and for clinicians who manage endometriosis, to remember that often pelvic pain is multifactorial. Endometriosis may not be the only, or sometimes even not the predominant contributing factor. In a lot of cases that we see with patients with endometriosis, it is, if not the predominant, a major contributing factor. But in a proportion of patients, there'll be other problems which may originate from the bowel, the bladder, gynecological problems such as endometriosis or adenomyosis, or ovarian cysts or fibroids or adhesions. So pathologies separate to endometriosis or different to endometriosis. There can be pains that originate from the musculoskeletal system or from the nerves themselves, neurological related pains, or pains which are neuropathic or have a psychological element or an element from the woman's mental health. And there is a direct relationship between chronic pain and mental health. And somebody who is in pain for a long time from whatever cause, their mental health on average will be obviously at risk, and pain negatively affects mental health and vice versa. So all these systems are in the mix, and they can contribute to producing the symptom of chronic pelvic pain. So when we start talking about treatment and how do we manage our patients with endometriosis, how do we provide relief, how do we offer, how do we relieve them from the symptoms? The choices start from conservative to medical to hormonal and surgical options, and we'll look at each of them in a bit more detail. So the conservative approach will include lifestyle changes. You'll be advised, you'll find valuable information in support groups such as Endo UK. You'll see online that measures such as CBT, which is cognitive behavioral therapy, or other talking therapies and pain management programs can help, both in the short and the long term of managing chronic pain. Physical therapy such as TENS machines, heat therapy, a lot of women find this very, very important for relieving the difficult days where the pain is at its peak. Endometriosis diets, which are basically diets based on antioxidants and reducing the oxidative stress, and relevant supplements. Several women find this helpful. Physiotherapy, and particularly women's physiotherapy, but also if there's a musculoskeletal problem, MSK or musculoskeletal physiotherapists can be very helpful. And a lot of patients find support from alternative or Chinese medicine, such as acupuncture. And essentially, all these conservative approaches, all these measures are down to to trial and error. It's about trying and see what helps, and keeping the things that help and moving onwards if something doesn't help. As long as it's something that it doesn't harm, you should feel free to do your own research, see what other people have found helping, and use those elements that help you. And it's not going to be the same for every woman, as everybody is different, and the disease itself behaves differently in every woman. Medical options include various medication, starting from simple pain relief, including paracetamol, ibuprofen, naproxen. Remember, paracetamol is the safest pain relief. It's not very strong, is not the strongest one, but it's, however, the safest. Therefore, it's always worth starting from that. Ibuprofen and naproxen belong to the category of drugs that we call non-steroidal anti-inflammatories, and when taken at for prolonged periods of times, you have to be cautious as they can cause damage to the kidneys and the stomach lining. Some of them, such as diclofenac, come in suppositories, which you insert through the rectum from the back passage, and they provide very good relief when the pain is bad, as they have very quick absorption through that route. Opioids are best used in the short term. They can cause problems such as dependency or constipation, and then constipation can lead to a vicious cycle of more pain. Opioids such as codeine, tramadol, or morphine. And there's other types of medications which we call neuromodulators, such as gabapentin and amitriptyline, which are change the way that the nerves respond to pain. Amitriptyline is an antidepressant, but it seems to work well for some people, some women with chronic pain as well. Moving on to the hormonal approach. So the pain relief and the hormones are two of the measures that, for example, your GP will usually start before, or at least they will offer to you before they refer you onwards. And it's often also treatments that we will offer you in specialist centers as well, if they have not been tried before. And these include the combined pill and other types of contraceptive pills, such as the mini pill, or long-term, long-acting reversible contraceptives, such as the implant or the depot injection or the Mirena coil. The Enogest is a little bit more special as a progesterone. It's like a mini pill. It's a progesterone-based drug, which seems to have a bit more efficient, a bit better effect on endometriotic tissue. We tend to favor it in women where other mini pills have failed them, or who have a definite and confirmed diagnosis of endometriosis. And Zoladex or Lupron, you might hear it, or the newest Rieco pill is the equivalent in pill of these injections. Zoladex is an injection, which makes you essentially menopausal. And often women, if they stay on it for more than 6 months, they will use HRT to prevent osteoporosis. The Rieco pill has recently been licensed for endometriosis, and conveniently provides both this suppression to the cycle and to your own hormones, but provides HRT at the same time, all built in one pill. And it seems to work well for patients with endometriosis. We don't promote long-term use of these drugs, but they can be a useful adjuncts to the management of endometriosis, including when we do surgery for endometriosis. And moving on to the surgical approach, the type of treatment that often women seek when they approach a specialist like myself. So there's a very, very, very important message that in this day and era, endometriosis, the surgical management of endometriosis should be done by keyhole surgery. Laparoscopy, whether this is the conventional laparoscopy or the robotic assisted keyhole procedure, endometriosis should not be managed by open surgery, because we know that it's not possible to treat all the endometriosis or diagnose it often by open surgery, and it can be detrimental, leaving a lot of adhesions behind, which makes subsequent procedures very, very challenging. Laparoscopy can be diagnostic only or therapeutic, or both. Often we diagnose it and treat it at the same time. Or if the disease is very severe and we want to get a picture of what might be going on in the pelvis and then move to treatment, we often perform a diagnostic laparoscopy sometimes first, and then move on to a second therapeutic procedure. Therapeutic meaning a treatment procedure. We believe that it should be done by excision and not by ablation. That doesn't mean that ablation doesn't never work. It works when it's done well and properly, but it has the disadvantage that it may miss disease that is not superficial, that it may go deeper into the tissues, whereas excision will remove the problem from its root. It will reach to the depth of the nodule, and it will ensure more complete treatment of the disease. Surgery can be fertility sparing, which means that, or non-fertility sparing, which means that if a woman wants to maintain her fertility, because she hasn't completed her family, we will be aiming to preserve important organs such as the uterus, the ovaries, the fallopian tubes, if they are functional, and resecting, which means cutting away or excising, in other words, the disease, from around these organs to give her a chance to have a pregnancy in the future. And it also, this type of surgery enhances fertility. Proficient and thorough excision of endometriosis can increase your chances of becoming pregnant naturally by about 30% in the long term, on average. Depending on the complexity and what organs are involved, we will have often urological, colorectal, or fertility input in planning and performing surgery, laparoscopy for endometriosis. Other ways, other techniques that help us are nerve blocks, which can be both diagnostic but also therapeutic. And of course, surgery comes with a certain level of risk, and we'll talk about that in a second. But women need to be fully counseled about the risk of surgery so that they can make an informed choice before they proceed to it. So we talked about why excision is superior to ablation and why it's considered today the gold standard for managing endometriosis surgically. In terms of the surgical risks, there are anesthetic risks. From the general anesthetic, there is a risk of infection, bleeding, risk of developing blood clots, and we do tend to give you blood thinning injections after the surgery to prevent that. The risk of damaging organs in your pelvis and abdomen, including the bowel, bladder, and ureters. But to put that in perspective, in the majority of cases, this risk is below 1%, so about 1 in 100 cases or less. So it does not happen often. And if something is injured, usually we're able to recognize it in the same operation, and we usually repair it in the same operation. This has usually little consequence for the future. We achieve a significant reduction in pain in about 70 to 90% of cases after surgery. So about 8 out of 10 women will have meaningful and significant improvement to their pains, and we usually measure that about 6 months after surgery. So we give enough time for recovery and for the women for a few cycles to pass so that women can see how the surgery has affected them. Unfortunately, it's a chronic condition. It can recur with a rate of 30 to 50% at about 5 years after surgery. And therefore, secondary hormonal suppression is important, which means a lot of women who don't want to become pregnant, at least not immediately, they will have surgery plus hormone suppression, which can slow down the recurrence of disease. Not all of these people will have surgery again. About 1 in 3 women has surgery, a repeat operation for endometriosis at some point in their lifetimes. A lot of them will manage it with hormone suppression, for example. And say for example, a woman who has wants to become pregnant, doesn't want to use hormones. She has subfertility related to endometriosis, but we treat her disease surgically, we remove it. She's able then to become pregnant. She has her baby or her babies in the next 2-3 years. She completes her family. Then she can go on a long-term hormonal suppression to reduce recurrence and manage ongoing symptoms or recurrent symptoms. And this can take her to menopause sometimes without the need for another surgery. The aim of the surgery is to restore the function and anatomy of the pelvis and the relevant organs, including the bowel, bladder, nerves, and to reduce the pain. That's the primary aim. As an extra bonus to this primary aim, we get the improvement in fertility rates following surgery for endometriosis, but the primary aim is to reduce pain. And that should be always the primary goal, or in the vast majority of cases, that should be the primary goal for endometriosis surgery. So now we're going to show you some images from inside women's pelvises, which will show the internal organs, the uterus, ovaries, bowel, and how the disease looks like. So if any of you doesn't feel like looking at these images, please turn off your screen now or bring down the brightness until it's black, or look away and you can join us in after 10 minutes again when these slides finish. So let's have a look at how normal pelvis looks like. So this is a normal pelvis. In the middle, you can see the uterus. I don't know if you can see my cursor here, but it is the uterus. These are the ovaries. The white tissue is the ovaries. Right ovary here, left ovary under this structure here, which is the fallopian tube. So this is the fallopian tube, which main purpose is to pick up the egg from the ovary and move it to the uterus for the baby to fertilize and implant. In front of the uterus, you've got the bladder under here, and it's covered by a membrane called peritoneum, which covers all of our insides. and that's where we find 70 to 80% of endometriosis. Remember, it's found on the peritoneum. Behind the uterus, we've got what we call the posterior part of the pelvis, where we often find severe forms of endometriosis, such as rectovaginal endometriosis between the rectum, which is the bowel, the gray tissue seen here, and the vagina, which is just below the uterus here. It's also called the pouch of Douglas. You may hear it as the pouch of Douglas, and often endometriosis and severe endometriosis is found here. The yellow tissue is the fat that covers the bowel. So this is a normal pelvis, and you can see a normal size uterus, normal size ovaries, normal and thin size fallopian tubes. By the way, these structures here are the round ligament of the uterus. So how does abnormal look like? Abnormal looks like this. You can see here the uterus, the uterus itself looks normal. The ovaries are of normal size. However, the peritoneum here has something which is endometriosis. You can see the black lesions here, some white lesions here, some red lesions here. It has varied appearances, endometriosis. It can be black, it can be white or pale yellow or red or bluish appearances. And that's why often it disguises, or it can be missed by people who are not specialists in endometriosis surgery and recognizing endometriosis. So that's because of the nature of the disease. It can take various forms. So this is an example of moderate endometriosis in a woman's pelvis, and you can see that something is not quite right. Here you can see an example of severe endometriosis, or we call it also deep infiltrating endometriosis. We start calling it deep infiltrating endometriosis when the disease invades more than 5 millimeters in thickness into the tissues. This is a video which will start playing, hopefully. Yeah, you can see here that the uterus is just about visible. There's an ovary here on the left, which is just about visible because it is stuck with adhesions. This is enlarged, and this is a fallopian tube that's enlarged around an ovary, which is underneath. And this is most likely a blocked fallopian tube. And this is the ovary underneath it. This is a case of severe rectovaginal endometriosis. The bowel comes in the middle. This gray tissue is the bowel, and it's stuck to the posterior uterus. So in the middle here, there is nodule. There's endometriosis next to the fallopian tube. There's endometriosis on the bladder as well. These are all endometriotic lesions, and there are severe adhesions. And we always do what we call a 360 inspection. So we turn our camera around to look at the upper abdomen, the diaphragm, the appendix, which is just coming under view here. So we can inspect endometriosis, whether there's endometriosis in other parts of the body outside the pelvis. So that's an example of a case of severe and deeply infiltrating endometriosis, which is the most inflammatory sort of forms of the disease, which get all the organs to get stuck together. Endometriosis of the ovaries requires some special considerations. This is endometriosis that implants either on the surface or inside the ovaries. Eventually, the ovary invaginates it, it surrounds it, and within the ovary develops an endometriotic cyst. This can be a small size, from under a centimeter to several centimeters, even to 20 centimeters or above in some rare cases. It damages the ovary, it causes inflammation. As the rest of the endometriosis in the pelvis, it has a damaging effect to the ovarian reserve in terms of the number of eggs of the ovaries over the years, and it poses a difficulty in treating it, because when we treat it, when we remove these cysts or we provide other treatments, you will see an example of sclerotherapy here on this video, where we drain the cyst and we insert alcohol in the form of ethanol in it to destroy the endometriotic tissue. When we do these treatments, unfortunately, some eggs are lost from the ovary inevitably. So here you can see we put an irrigation system in the ovary that sucks away the fluid of the endometriotic cyst and washes it. Then we insert a catheter into the left ovary, and through this catheter we insert ethanol, which is alcohol, 96% alcohol, into the ovary, which destroys, essentially, makes the endometriotic tissue inside inactive, and this still damages some of the eggs of the ovary, but less so compared to other techniques. So this is one of the techniques that we have to manage endometriosis of the ovary in the form of endometrioma, as we call the cysts. Adenomyosis also requires some separate discussion, and it can be a whole different lecture, but essentially it's a sister disease of endometriosis. It appears, the location, it's a very similar disease, but the location differs. So whereas endometriosis lives anywhere outside the womb, adenomyosis specifically lives inside the wall of the womb. So the wall of the womb is made of muscle, and within the muscle tissue, adenomyosis implants and grows, causes inflammation, pain, and usually heavy and painful periods, and also has been linked with infertility, subfertility. Often it coexists with endometriosis. You can have both diseases at the same time at a varied degrees. You may have severe adenomyosis but very little endometriosis, and vice versa. You can have severe endometriosis and very little adenomyosis, or you can have one without the other, although this is less common. So because it's heavy and painful bleeding, it's more linked to heavy bleeding compared to endometriosis, because endometriosis bleeds in the abdomen as opposed to adenomyosis that's inside the womb. It can be detected on imaging, or either on ultrasound scan or on MRI, but it is difficult to be sure that somebody has adenomyosis unless it is examined histologically if a woman has a hysterectomy. So if the whole womb is removed and examined under the microscope, usually then only then we can conclusively prove that somebody has adenomyosis, or disprove it and say that they don't have adenomyosis. And the scans can get it wrong sometimes. Hormonal treatments are often very helpful, such as contraceptives. The Mirena coil often is very helpful because the drug works straight into the womb where it's needed, and the hysterectomy is the only permanent cure for adenomyosis, as opposed to endometriosis, which can recur once you remove it. If you remove the womb, clearly adenomyosis will never recur. But of course, that's an option only for women who have completed their family. And you can see here that this uterus is not normal. If you compare it with the previous image, you can see that it's more enlarged, it's more wide, and that's because of adenomyosis inside it. So planning how to become a parent, to become a mother when you have endometriosis. One important message is to seek fertility referral early. If you have a definite diagnosis of endometriosis, if you have severe endometriosis in particular, there's a possibility that tubes may be affected. In few cases, one or both fallopian tubes may be completely blocked, and you will not become, in which cases, women will not be able to become pregnant naturally, but they will need fertility treatments such as IVF. But fortunately, these are the minority of cases. The vast majority of patients with endometriosis will become pregnant, and most of them will become pregnant naturally, but it can take a bit longer. It can be harder to become pregnant when you have endometriosis. That's why when we excise it fully and proficiently, we get a 30% boost in our fertility chances, in our chance of becoming pregnant naturally. Egg freezing can be considered, particularly for women who have endometriotic cysts or low anti-Mullerian hormone, which is a blood test that we do to check the reserve of the ovaries in terms of how many eggs they've got. It's a crude assessment. It doesn't tell us exactly how many eggs the ovary has, but it gives us a level of whether somebody has a lot of reserve or low. And it helps us plan our surgeries in women with ovarian endometriosis in particular. While you're pregnant and once you're pregnant, you may have slightly higher chance of preterm birth, abnormally growing placenta, or cesarean delivery, but these should not despair you. The differences are not massive, and a lot of things can happen when somebody is pregnant. It looks like if you have endometriosis and adenomyosis, you may have slightly higher chances of these problems. But again, most of the pregnancies will be absolutely fine with endometriosis. So moving on to one of our last chapters is we'll talk about a few myths and misconceptions around endometriosis. One of the things that we used to believe in the past, some decades ago, was that the hysterectomy was a treatment for endometriosis, where it clearly is not. By definition, endometriosis lives outside the womb, and therefore you don't treat endometriosis by removing a womb, but by having a hysterectomy, but you certainly treat and cure permanently adenomyosis. Also, the pain may not be cured permanently, because often the pelvic pain is multifactorial, as we said, and endometriosis itself can recur. However, as we said, hysterectomy guarantees two things. It will cure your adenomyosis, and you will never bleed again. So if a lot of your pains come with bleeding and with the periods, or if a woman has heavy periods or irregular bleeding and she has tried other methods, if she has adenomyosis at the same time with endometriosis and she has completed her family, it makes sense to offer a hysterectomy if she wants it. And it's a sensible thing to do. It reduces the possibility of needing repeat surgery for adenomyosis, for example, in the future. But it makes no sense in a woman with endometriosis to perform a hysterectomy and not address the endometriosis, which can be a major contributor to her pelvic pain. So often we do women with a hysterectomy who require a hysterectomy for whatever reason and have pelvic pain. We will do both at the same time. We will excise their endometriosis and perform a hysterectomy at the same time if the patient wishes. Myth number 2, pregnancy does not cure endometriosis. It can make things better for a while you're pregnant, because while you're pregnant, your placenta produces large amounts of progesterone. So it's like being on a very strong contraceptive. So similar to the way that contraceptives suppress endometriosis and adenomyosis, similarly, the pregnancy may, for many women, do the same. Also, you don't have periods while you're pregnant, you don't bleed, and a lot of women, a lot of the pain comes with bleeding. So it can temporarily improve symptoms due to the hormonal changes, but it doesn't take endometriosis away. Can endometriosis turn into cancer? It's important to remember that endometriosis is a benign disease, that means not cancerous. It's an unnecessary source of anxiety, this kind of concern. Remember, any part of our body, unfortunately, can turn into cancer, any type of cells or tissues. There is a slightly increased risk for endometrial cancer in women with endometriosis, but this remains low. Rarely, ovarian endometriotic cysts can be linked to slightly increased risk of ovarian cancers, but this is not a reason to remove endometriosis. So we wouldn't remove endometriosis in a woman who doesn't have symptoms, is not in pain, only because of the possibility that this may become cancer in the future. This is not a legitimate reason to go through the risk of surgery if you don't have symptoms and it doesn't bother you otherwise. So not something to worry about. So finally, it is important to try and get the right type of help at the right time of time and in the right place. Fortunately, we live in an era where there's abundant information out there. Unfortunately, some of that information is not good information or it can be misleading. So be mindful of your sources, where you read this, which sources you choose to educate yourselves and inform yourselves, but it's all at your fingertips now. Choose a reputable source, such as in England, in the UK, we've got NICE, the National Institute for Health and Care Excellence, which produce various guidelines for lots of different problems, including endometriosis. Got a very good support group and forum called Endometriosis UK, and they've got a very informative webpage. The NHS has built up a very good information, online resource of information, and you can find valuable information from there. There are online forums on Facebook where you can find valuable information, but also be mindful, use your own judgment, and use your own judgment to lead yourselves to the right place. So, for example, if you approach someone who claims to be an expert endometriosis surgeon but performs only ablation and never excision, or who claims that he can manage any type of endometriosis but doesn't work within a multidisciplinary team with colorectal surgeons regularly, for example, doesn't work regularly with colorectal surgeons, then be aware, do your own research, use your judgment, and if you're not getting the help that you need elsewhere, find a team that specializes in endometriosis and functions within the context of the multidisciplinary team of specialists, all with experience in endometriosis in a place such as the Runnymede Endometriosis Center. So that concludes our slides. Thank you for your patience and sitting through all the slides this evening. And now we can I can stop sharing my screen, and my Ellie and Tracy are nodding to me and saying yes, that I can stop now, and we can go to your questions if you have any. And let me enlarge this and see if there's anything that we can answer. So this is the chat, this is the Q&A. So we've got a question from anonymous user. Isn't there anything specific? So I'll read out the question and then I'll answer it. Isn't there anything specific your GP needs before referring to a gynae doctor? And can I choose the gynae I would like? Can I self-refer to a gynae? So in the NHS, the referral to the NHS system, to an NHS gynecologist, has to go through your GP. You can't choose to be referred to the gynecologist that you want to, particularly when you're seeking specialist care from a specialist endometriosis center, for example, with specific gynecologists that you've done your research and you want to approach. You can ask your GP to refer you there. And to the best of my knowledge, most GPs are able to oblige with that. The GP will need to see you, they will need to take your history, they will need to raise their own suspicions for endometriosis. They will often do some initial management, as we discussed, though they should usually request an ultrasound scan as a minimum. If the ultrasound scan shows evidence of deep endometriosis, such as ovarian endometriotic cysts, which is one of the few things that the ultrasound scan can pick up very well in endometriosis, then that suggests that there may be deep disease elsewhere, and that builds up your case for a referral to a specialist gynecologist. Similarly, if the GP starts some initial treatment, for example, with hormonal contraceptives plus pain relief, and you return to him after 4 or 6 months and say that, thank you very much, but this hasn't helped with my symptoms, I'm still in a lot of pain, or it has helped me a little bit, but I want to explore what other options I have, then he should be obliged also to refer you onwards. In the private sector, things are a bit easier in terms of this barrier is not there. I appreciate that obviously the main limit in the private sector is the cost, but you can approach, you can refer, you can self-refer, you can approach a gynecologist in the private sector yourself. You can, again, you'll do your own research, you'll find the details of all of us online, either an email or a telephone number. You can approach and inquire about an appointment. And as far as I know, the vast majority of gynecologists, myself included, would be very happy to see you if you're in pain, even if you don't have a GP referral. So I hope this answers this question. We'll move on to the next. Does menopause cure or bring relief to stage 4 endometriosis? And if so, how? And how should you manage endometriosis during perimenopause and menopause? That's an excellent question. Unfortunately, we would need several hours to talk about everything around endometriosis, so we didn't touch upon the subject of endometriosis after menopause. But endometriosis doesn't usually cause severe problems after menopause, but what is unusual is not impossible. So it is possible to have problems with endometriosis and symptoms after menopause. It is on a few occasions possible to have severe problems from endometriosis, particularly with stage 4 endometriosis, which can erode through organs even after menopause. And the management is after menopause is usually based on surgery and pain relief. Hormonal treatments, in the absence of your own circulating hormones, which you don't have after menopause, any additional hormonal treatments will not make significant difference. So the one thing that differs is that the mainstay of treatment after menopause will be either pain relief or surgery. So hormones will not be valuable after menopause. It does improve usually symptoms of endometriosis, menopause, and that is because endometriosis is a hormone-dependent disease. So it is your own hormones, your own circulating hormones feed endometriosis, and they inflame it every month. and it is the cyclical change of your hormones that make endometriosis an inflammatory condition. If you give a steady supply of hormones through a contraceptive that you take the same dose every day, then endometriosis tends to be suppressed. But when you have a cyclical change of hormones which goes up and down because of your natural cycle every month, that's when it gets inflamed and mostly painful. So this absence of this cyclical monthly change of hormones after menopause is what makes the endometriosis less symptomatic and less inflammatory, but it doesn't go away. It stays there. It can regress it will regress to a degree. It will be less active and less inflamed. But the scarring that we will have created by that stage will never go away. And because you specifically ask about stage 4 endometriosis, unfortunately, stage 4 endometriosis leaves usually significant scarring behind. That doesn't go away after menopause unless it is removed by surgery. So the organs, if they've never been treated, they'll be stuck together, and that they will continue to be so after menopause, even though the disease itself will not be so active. And that can cause these adhesions, these organs being stuck together, and the dense scar tissue that it creates can cause pain in its own right. With perimenopause, again, it's the same answer. Essentially, around perimenopause, there is still some circulating hormones, although they're not consistently cyclical. Some hormonal treatments may help. Again, pain relief and surgery can still be very helpful, particularly for severe endometriosis, which carries usually a lot of scar tissue, which needs to be excised together with the disease. Okay, so I hope that answers that question. What are the recommendations for hormone treatment during perimenopause? So in a woman with endometriosis, a woman with endometriosis should always have combined HRT. If that's, I guess you're not talking about hormone replacement treatment, you're talking about hormone treatment in general for endometriosis. So I think that goes to the previous question about treatment options during perimenopause and menopause. During perimenopause, there's still some circulating hormones. So again, all the same treatment options are there, whether that is pain relief or a hormonal contraceptive. However, after the age of 45, you should not be using combined pill because of the risk of blood clots, and therefore you'll be prescribed something that is based on progesterone, and that would be either a mini pill or a Mirena coil or Dienogest to avoid the risk of blood clots. Progesterone does not carry a risk of blood clots, whereas the combined pill that contains estrogen carries a risk of blood clots. So that would be the hormone treatment option during the perimenopause and after the age of 45. Let's go to the next question. I have been on a progesterone-only pill, Dienogest, for 8 years as a way to manage my symptoms. I intend to stay on this till I would like to have kids. Are there any adverse impacts in using such contraceptives for 8+ years? And what should I bear in mind when I would like to conceive? So the long-term use of progesterone-only pill has been linked to a couple of problems, although the benefit that you get from it is thought to outweigh these problems. One of the problems is the link to breast pathology, and the other problem is that it can slowly deplete or reduce your bone density, because it reduces also, over several years of use, it can reduce a bit the estrogen production from your ovaries, which feed your bones, which promote mineral absorption by your bones. So after several years of use, the mini pill may be linked to a reduction in bone density. And therefore, like all of us in a northern European country, like England, we should all take vitamin D because there isn't as much sunshine. So you should look after the health of your bones by taking vitamin D daily, getting enough calcium from your diet or supplements if needed, and do regular exercise, including weight-bearing exercise. Weights can strengthen your bones. What you should bear in mind when you want to conceive, with progesterone contraception, the good thing is that once you stop it, usually your fertility and your cycle returns quicker than if you are on a combined pill, for example. So that's usually less of a concern. again, long-term of any hormonal contraceptive can, when you stop it, it may take a little while for your fertility to come back and your cycle to come back. So perhaps you should stop it ahead, 6 months ahead of the time that you want to start trying conceiving or something like that. But other than that, I cannot think of any adverse impacts in terms of future pregnancies or future fertility. In fact, if anything, if you have endometriosis, the progesterone will suppress it, hopefully, and it will stop it or slow it down from growing further over the years, and hopefully that should have a positive impact when you want to stop it and have children. What happens when a woman is in pain with or without bleeding? Chronic pain regardless of time of the month. So what happens when a woman is in pain with or without bleeding regardless of the time of the month? So endometriosis and adenomyosis are classically related with cyclical pain, or at least cyclical worsening of the pain. So pain that worsens when you're on a period, or the premenstrual pains, but also pains with sex. But a lot of women will have also pain throughout the cycle. That's not uncommon. And however, when the pain has nothing to do with the cycle, so if a woman, for example, tells me that I'm a lot of pain on random days in a month, but when my period comes, I feel a lot better, or the premenstrual or days during periods are not particularly painful, then I will start looking for other causes of pain as well. I will still look for endometriosis because that's my job, that's what I do, and it can be often a contributing factor. But as we said, pelvic pain is often multifactorial, and we have to look at the bowel system, urological system with the bladder, musculoskeletal system, the pelvic floor, nerves, neuropathic pains, psychological, mental health, and all these issues that come into the mix and often produce pelvic pain. And often there'll be specific triggers that will give us a direction. So, for example, if the pain is associated with bowel function, if you pass mucus from your bowels or blood, and the pain comes when you have loose motions, then we have to investigate the bowel, and I will be referring you to a bowel specialist, for example. And as endometriosis surgeons, we've got links with all these various specialists who deal with pain and problems of the various organs that live in the pelvis and can produce pain, and would be pointing you to directions to the various specialists. And a lot of the time, it's about going through the motions, going through the different specialists, and each of us will do our investigations to try and see what's wrong or what's causing the pain. And depending on what we find, we will provide a relevant treatment. If it turns out that it's endometriosis mostly the problem, but for some unusual reason it doesn't produce pain on the menstrual days, but it produces pain on other days, then again, we will treat you for endometriosis. Moving on, are there any new diagnostic treatments? Are there any new diagnostic treatments which do not require surgery? So, a new diagnostic, I'm just trying to understand the question. So, diagnostic is not treatment. So, diagnosis and treatment are two different things. In terms of new diagnostic methods, there are some methods which have been promoted recently where they detect certain elements in a woman's blood or saliva. And these some of them claim that they can detect endometriosis with very good accuracy. Some of them are costly. We believe that the laparoscopy is the gold standard for endometriosis, and it is likely to stay the gold standard for the foreseeable future. But there is work being done globally on other diagnostic methods. Treatments other than surgery, as I mentioned recently, a pill called Rieco has been licensed, which is not entirely new. It's got some media attention recently. It's not new, it's in a new form, essentially. We didn't have it as a pill before, but it's the same drug with Zoladex injections, which make you menopausal, and it contains HRT in the same pill. And so you take with one pill a day, you take both the medication that stops your own hormones and makes you menopausal, which means it stops inflaming and stimulating endometriosis, but at the same time, it gives you the hormone replacement in a steady supply, which again suppresses endometriosis, but also protects your bones from osteoporosis. There are some new non-surgical treatments for adenomyosis. Again, not very new. They've been around for a few years, but relatively new compared to the other methods. Where you can have for adenomyosis when it's concentrated in a specific area in the form of an adenomyoma, so which is bigger than 2 centimeters in the womb. This can be ablated. It can be destroyed essentially by an ultrasound. So they do an ultrasound specific. They do ablations with high frequency ultrasounds machines through the vagina, and it's non-invasive, non-surgical method of treating adenomyomas, which is concentrations of adenomyosis in the womb that have to have a certain size, 2 centimeters and above, to treat those. Moving on to the next. Does a hysterectomy result in other problems because organs can move around due to the womb no longer being there? So that's a good question. There is no known problem from the organs replacing the space where the womb should be. The womb, unless it has very large size because of problems like if it has severe adenomyosis or fibroids, then it will be enlarged. And then it will itself occupy the space where other organs should be. So when you remove a very large and abnormal womb because it has disease, then the organs will actually more or less fall into the place where they should be in the first place. But they couldn't be there because the womb was very large, or they were being pressurized by the womb. And therefore, very large adenomyotic womb or wombs with fibroids can cause problems to the bladder or the bowel because they compress these organs. So when you remove a truly very diseased womb, actually the rearranging of the organs inside is actually beneficial. A normal sized womb doesn't occupy too much space, and there won't be a lot of rearrangement from a physical perspective if you remove it. The organs will the bowel will comfortably sit where the womb would be, and that shouldn't cause a problem. But the surgery can leave some scarring. It will interrupt some nerves carried by the uterosacral ligaments, which attach to the womb when the hysterectomy is performed. And therefore, there is the possibility to develop some symptoms from the scar tissue. But usually when a hysterectomy is done for good reasons, if there's a lot of disease in the womb, then usually you get relief because you don't have that disease anymore. But you may have some symptoms from the scar tissue, although these usually should be less than what you had before the womb was removed. If a hysterectomy is done for the wrong reasons, so if somebody claims to cure endometriosis by doing hysterectomies, but leaves the endometriosis inside, and then does a hysterectomy and removes a normal organ, then the woman is not going to feel better. In fact, it is possible that she may feel worse following such kind of surgery. Hopefully, this should not happen this day and age. Next question. All very good questions, by the way. All really, really nice questions. I've been using etorocoxib for inflammation and omeprazole to protect my stomach. Do these have any long-term effects? Well, I'll have to Google that. Etorocoxib to see what class of drug it is. Etorocoxib. Oh gosh, autocorrect changed this to something completely unrecognizable. Etorocoxib. Give me a second. I may or may not be able to answer this question. I'm not a pain specialist. But a pain specialist should be able to answer this. So it's a selective COX-2 inhibitor, a type of non-steroidal anti-inflammatory, primarily used to alleviate pain, inflammation, used in osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, acute gouty arthritis, so really severe painful situations. This is being used, associated with non-selective. So it's a selective COX-2 inhibitor. So I don't have experience with this medication. I don't prescribe it. You'd have to speak to a specialist, pain specialist, to get more information. You're using for inflammation. I'm not sure where this inflammation comes from. Do you mean that's from endometriosis, or is it from something else like arthritis, for example? Omeprazole will protect the stomach lining from non-steroidal anti-inflammatories. but I don't use this medication, I wouldn't be able to tell you whether this drug has any long-term effects otherwise. But if it improves your pain, then and you need to have it because you've been prescribed it by somebody, then I guess you should use it. I'm not aware that it may have any adverse effect on the endometriosis course, for example. I don't think it would make it worse. Last question on my list. If you have endometriosis excised and have the Mirena coil fitted, but still suffer symptoms as adenomyosis is suspected, would a hysterectomy mean the hormones are repressed, so endometriosis doesn't have the hormones available to grow? Would it depend on if the ovaries are left? Very good question. So if you are in your 30s, for example, or your early 40s, most of us specialist endometriosis surgeons, if you needed a hysterectomy or you decided to have a hysterectomy because of adenomyosis, for example, and we have done the endometriosis work, we've excised the endometriosis, and this hasn't controlled your symptoms, and both you and your surgeon thinks that the hysterectomy would help, and there's evidence of adenomyosis on a scan, for example, or the bleeding is still very painful, the periods are still very painful, then normally in a young woman, we would usually advise that you keep the ovaries, you maintain the ovaries. If one of the two ovaries has disease, for example, it has an endometriotic cyst or is badly stuck because of previous treatment of endometriosis, then you could have one ovary removed. The other ovary will take over the hormonal production, and therefore you will keep your own hormones because the hormones are produced by the ovaries. The womb doesn't contribute to your hormonal system. It doesn't produce hormones or significant amount or any hormones that circulate into your circulation, to your system, and provide benefits to the rest of your body. So the presence of the womb itself doesn't provide hormonal support for you. As long as you keep at least one ovary inside, you will have hormones until later in life, until you go into natural menopause. Some studies some earlier on showed that possibly if you have a hysterectomy, you may go into menopause on average 1 or 2 years earlier than a woman who didn't have a hysterectomy, even if you maintained your ovaries. That could be because the ovaries take part of the blood supply from the uterus, but they only take 10 to 20% of blood supply from the uterus. They take 80% of the blood supply from the aorta, and that supply is maintained even if you remove the uterus. But the part that they take, the vessel that they take from the uterus, that is cut and sealed. So because they lose that, perhaps they may fail a little bit earlier. However, nowadays where we do very precise, very delicate laparoscopic and keyhole work, that is probably less of a concern. And if it fails after a few years and you go into menopause, if it doesn't produce hormones, you can go on HRT, and that is often adequate. So yes, you will have your hormones if you keep at least one ovary inside after a hysterectomy. And that concludes all the questions. Very, very good questions today. Very nice discussion, even though it's just me talking, but we couldn't do it any other way. It's been a very nice discussion. And thank you to everybody who stayed tuned in. And I'll hand over to Ellie and Tracy to close the session. Hopefully, I'll see you in one of our future webinars. Thank you. I'll mute my mic.
Thank you very much for coming along to the session. We have some details here about how to book an appointment with Mr. Minaz, or you can take down the phone number or the email address listed there.
Yeah, and we can happily assist with any prices that you may need or book in a consultation with Mr. Minaz.
Thank you very much for coming along, everyone. Bye.